Every day, thousands of people, including our family members and loved ones, are being struck down by sudden cardiac arrest. Improving survival from cardiac arrest is not complicated, but it's also not easy. The very nature of cardiac arrest requires bystanders to be ready, willing, and able to act. In a pre-hospital system where EMS first responder agencies are coordinated and integrated in their approach to a choreographed group effort, with the focus of being neurologically intact survival to discharge from the hospital. Hi, I'm Robbie MacCue, your host on today's EMS Leadership Summit session. And we've lined up an expert panel of some of the best resuscitation experts who are out to challenge sudden death. We're joined today by representatives from two premier organizations, the Resuscitation Academy from Seattle, Washington, and the Citizen CPR Foundation, whose mission is to strengthen the chain of survival and hosts a cardiac arrest resuscitation conference, bringing together stakeholders for over 30 years. So I'd like to introduce our first two guests, David Hiltz and Ann Dahl. David, Ann.
Hey, Robbie. Thanks so much for having us on. My name is Dave Hiltz, and I am here representing the Citizen CPR Foundation. And again, thanks for having me on.
Absolutely.
Hey, Robbie. Hey, everybody. My name is Ann Dahl. I'm the Executive Director of the Resuscitation Academy Foundation in Seattle, Washington.
Great. Well, thanks to you both for being here, for bringing your organizations together to have a conversation about resuscitation. And we also have two additional experts from your respective organizations in the resuscitation world. We have Dr. Tom Ray, and we'll bring Tom in.
Hey, Robbie. Tom Ray, Seattle, Washington, and the Resuscitation Academy. Thanks for having me. Good to be here.
And we'll bring Jim in. Jim, can you hear us?
Yep, I can hear you. Robbie, thanks for having me on. It's a pleasure to be here. I'm a EMS medical director in southwestern New Hampshire, and I serve on the program advisory committee for the Citizen CPR's Heart Safe Communities.
Great. Heart Safe Communities, I think a great place to start. If we do start, Dave, can you give us a little background on Citizen CPR and you know those efforts of Heart Safe Communities?
Yeah, so that'll be kind of intertwined into my introductory remarks, Robbie. So we've got a bit of a pregame plan, but we haven't practiced anything, so you're all going to be able to be witness to that. But I thought it would be an appropriate place to start in talking about, you know, what does an ideal cardiac arrest community look like, right? And that'll segue nicely into some of the other subsequent discussions. And then we're really looking forward to your moderating, you know, kind of an open discussion and your probing questions. So, you know, again, Robbie, on behalf of myself and the Citizen CPR Foundation and the Resuscitation Academy, you know, thanks for having us on. It's our collective hope that our efforts here inspire change and help to save more lives by preventing sudden cardiac arrest from becoming permanent sudden cardiac death. And, you know, I wanted to take a few moments on the front end of our session to talk about this ideal community. My intent is to illustrate what's possible today with the science, tools, and strategies that are immediately available to all of us. This will set the table for subsequent remarks made by Tom on why we're not winning the war against sudden cardiac arrest, and by Jim on the critical importance of EMS leadership, and by Ann on kind of an introduction to strategies to improve survival outcomes. So many of my comments will be garnered not only from the teachings of, you know, the Resuscitation Academy, but also what I've learned at the Citizen CPR Foundation, but more importantly, from the Institute of Medicine study and report that was sponsored by the American Heart Association, the Red Cross, and a host of other organizations, and was published in 2015. And I'd encourage your audience to visit your virtual exhibit hall to look for links to this and other valuable documents. You know, this document is rich with information, guidance, and resources. And again, I encourage all of your audience and attendees to to access it and utilize it. As you're all aware, I'm hoping that I'm preaching to the choir to a certain extent, is that cardiac arrest is an equal opportunity killer that can strike down seemingly healthy individuals of any age, race, or gender at any time and in any location, and often, unexpectedly and without warning. And the vast majority of these occur in and around the home, like 80%. Out of the hospital, in a private residence. And, regretfully, 90% of these folks pass away permanently, death, right? And so, I believe that it's absolutely essential that we recognize sudden cardiac arrest as a significant public health and communal issue. That really requires us all to have all hands on deck. I think in order for us to save more lives, we need to leverage local resources to improve preparation, recognition, response, and immediate care by the citizenry, as well as high quality care by our ambulance services and our healthcare system. Time is clearly the enemy here, Robbie. And we need to work diligently in a coordinated and systematic fashion to reduce time between onset of arrest and the provision of initial life-saving treatments, often provided by bystander witnesses. This is a fundamental strategy, and shortening this time is one of the most effective ways that we can improve outcomes. Specific actions can be implemented now in every community to decrease time to detection and treatment of the suddenly collapsed victim. So I'd like to take an opportunity momentarily. I'm going to plug the Resuscitation Academy with one of their mantras, right? And it's perfect. And it goes something like this. It's not complicated, but it's not easy, right? I mean, we've all known about the chain of survival for more than a week, right? It's been around for quite some time. And the science behind the steps to improve survival are not difficult to understand and are fairly straightforward. But change must start at the local level. It's the local medical, administrative, training, and other folks who are most accountable and can best decide how to bring about change. It's important to understand that the very nature of cardiac arrest requires bystanders, again, to reaffirm what you said, to be ready, willing, and able to act. And then that needs to occur within the system that integrates all these little pieces together, right? Because no matter how many people we train, no matter how many AEDs we place out there, no matter how well our professional rescuers are performing resuscitation, no matter mobile ECMO and all of this other stuff, if we can't put it all together in a logistical manner, it's not going to yield the type of results that we're looking for. So organized community strategies that prepare the lay public to provide bystander CPR and rapid defibrillation offers the best opportunity for successful resuscitation in the initial minutes after cardiac arrest. So we want to change, bystanders into tristanders. And, there are numerous opportunities for improvement that are rooted in engaging and educating the public. The centralized collection and distribution of cardiac arrest-related data, the use of that data and quality improvement on a local, regional, and national level, as well as the provision of high-quality care by our EMS and healthcare systems, as well as improved stakeholder collaboration. Despite the prevalence of cardiac arrest, federal support for resuscitation research pales in contrast to other diseases and conditions that are just as common. And compelling new research holds promise for boosting survival. But again, implementation remains the key. The fountain of youth, if I may. So what is an ideal community anyhow? You've been waiting for me to talk about this. So, Here we go, right? So the ideal community is one that recognizes the significant threat and impact of sudden cardiac arrest and has made it a localized public health priority and takes aggressive measures to improve preparation, recognition, improving response, improving the quality of care rendered by its first responders and the EMS system. Bullet number one. Bullet number two, the community has committed in an official capacity to the formation and support of a task advisory group dedicated to the issue of sudden cardiac arrest. Furthermore, the community uses their EMS system to lead and coordinate efforts related to cardiac arrest outcome and improvement, right? The community collects and utilizes data to develop, measure, and support their localized strategies. The community offers extensive public education in recognizing and responding to sudden cardiac arrest. They enhance the notion that performing immediate life-saving measures is both a civic duty and a moral obligation amongst the citizens. The community values citizen or tri-standard actions and provides recognition for those who render aid to others in their critical time of need. The community develops and implements strategies for the strategic placement of automated external defibrillators and makes them accessible on a 24/7 basis whenever and wherever possible. They have instituted telephone-guided tri-standard CPR and has an AED registry that is integrated with their 911 system. They foster the development of effective emergency action plans for households, businesses, schools, and public venues. They conduct periodic multi-party or multi-agency cardiac arrest drills to validate the effectiveness of response and identifies areas needing improvement on a regular and ongoing basis. They equip, train, and support first responder rapid defibrillation strategies, including equipment, effective protocols, active medical direction, post-event debriefing, including event reconstruction and review of all available data. They support the development and practice of high-performance CPR in their EMS system, as well as in their receiving hospitals. They share publicly cardiac arrest progress reports that include bystander CPR and AED utilization rates, as well as outcome data on a regular and ongoing basis. And lastly, they have instituted primary and secondary prevention strategies aimed at improving the overall cardiovascular health of their population. You know, Robbie, this vision is well supported by science and current treatment recommendations and can be augmented by additional measures and strategies such as ECMO, evolving technology, and more. These measures will pay out dividends in the form of lives saved. However, we will only truly prevail if they are implemented in a manner where we can appreciate and capitalize on the synergistic properties associated with them. A cardiac arrest should not look like a bull run in Madrid, but rather a well-choreographed dance routine designed by Jerome Robbins. And then lastly, one more Resuscitation Academy mantra. It takes a system to save a victim. Given the unpredictable and catastrophic nature of sudden cardiac arrest, not to mention the brief therapeutic window of opportunity, it is remarkable that anyone can be resuscitated. It is amazingly complicated and difficult to save a victim of sudden cardiac arrest. However, success is entirely possible. There is hope for saving hearts too young to die, and life-saving is the ultimate form and expression of hope. Robbie, back to you.
Well, Dave, I think that's what they call a mic drop in summarizing the epitome of what it means to really, be a community focused on survival. And I think those are all excellent points. Maybe we could turn it over to Anne to talk a little bit from a perspective of Resuscitation Academy. And I know for years your organization has really been pivotal in training the professional rescuer component of that, and maybe you could just give us a little more background on your insights to this.
Well, sure. So the Resuscitation Academy was created in 2008 as a way to try and kind of formalize and bottle what the success that King County and Seattle have had around resuscitation survival rates over the years. And our good fortune is that our system was created by academic EMS and cardiology researchers who were there to help create the EMS system itself. So from the very beginning, the question was always asked, how can we do better? How can we improve? How do we need to fine tune this machine just so that more patients survive? And with those as the roots of our system that measure and improve kind of foundation and mantra that we hold so dear, over years, the system enjoyed some success. And so in 2008, we got busy creating a curriculum around trying to translate that success into other communities. And Tom can jump in here because Tom was there at the very beginning, but I think what's been fantastic about that experience is that as people came to Seattle to learn about how we manage community CPR training, EMS provider training, training for telecommunicators or dispatchers to manage cardiac arrest calls, the more that we taught, the more that we learned about other communities' challenges and implementation. And so that really just started to snowball us into really diving into this world of implementation science and how do we take the good science that's on the shelves in all those academic journals and break it open and put it down on the work table in the fire station and work with EMS folks and 911 or comm center folks to see how together we can save more lives. But Tom, you probably have a different view yet.
No, so thanks, Anne. Again, Robbie, I'll jump in. I mean, I do think the Resuscitation Academy is really about how to implement science, right? It's about implementation. David mentioned that sort of the science is global, but implementation is local. And the science is really not a mystery on many fronts, but successful implementation perhaps is still sort of an uncharted journey. So I think we really tried to do a self-examination of why we've been able to implement some programs well and others not so well. And that sort of became a think tank for other communities as well. And so when people come to the Resuscitation Academy, we learn as much as they do, we hope, we think. And we challenge those folks to think about implementation and the details of leadership and accountability, change management, evaluation, and improvement, right? And these are all sort of core concepts for implementation no matter what field you're in. And I think they're especially pertinent in resuscitation because it is an exceptional challenge, as David mentioned.
Well, and again, I think it alludes back to what Dave said, and what's been said here is that, success leaves clues. And if you can focus on what's been working and you can bring that to the local level, they say, what all politics are local. Well, it sounds like all resuscitation is local in these steps that have been outlined by, again, your two organizations coming together to advocate for both the pre-hospital world and creating excellence. And then how do we get the bystander component of that in there? So I guess, Tom, too, what do you think are the reasons why we're not winning, as Dave said, the war against sudden cardiac arrest or our inability to bring these pieces together?
Yeah, so that's That's I think a bit of a loaded question. And so first of all, I'll qualify that, you know, we every day people are saved. And so there are important successes all the time. And we should not underestimate how important those successes are. But sort of as you take a step back, you say, boy, the goal should be to see, you know, big leaps forward, big success. We have the science at hand. Why can't we have you know, big progress? And it is useful to understand that if you look across the U.S., there is a wide variability in terms of outcomes, right? And so for people to say, well, it's just too hard, I think, you know, you need to look at some communities where survival from all rhythm arrest, all comers, is 20 or 25%. For VF is over 50%. And so I think for us just to simply say it can't be done flies in the face of what is accomplished in some systems. So I think that's the backdrop. I think you know David did a wonderful job of summarizing things, and I'll be brief here. But I think the first thing is time, right? That's an immense challenge. David called it the enemy. It absolutely is. And if you contrast cardiac arrest and resuscitation to other emergency conditions like stroke or ST elevation, MI, you know, they are characterized in minutes to hours, and we are characterized in seconds to minutes, right? And again, the sheer challenge of that is just remarkable. And so I think that's one real domain that makes it difficult. I think the other thing to think about here is who the rescuers are, right? When we think about, again, STEMI or stroke, you very quickly are funneled in to a specialty group of nurses and physicians, experts. And so you have this cadre of very finely trained folks who have that window of time to do their specialized and well-practiced skills. In resuscitation, you don't have that luxury. So the rescuers really become the range of folks David mentioned. And in fact, the most critical rescuers are the ones with the least experience. And quite frankly, those that have the least expectation to act, but really most importantly, need to act. And I think the final thing to think about is just the nature of the condition, right? Cardiac arrest is devastating, right? You're dead by all accounts. And these other conditions, while very serious and can produce death, you're not starting behind that huge 8 ball like you do. And so when you put that collection of realities together, it really is an uphill battle that requires sort of immense effort. You can never sort of relax or coast, rely on your laurels. Every case is that much more challenging than the prior case. And so it really takes, it takes a concerted effort by the system, accountability, leadership, all these things to demand that you push on all these links to make them successful. So I think time, the nature of the rescuer and the collection of rescuers, and then I think that the condition itself all conspire to make it really difficult to improve resuscitation. And yet, we do have improvement and we do see success. And again, I think it's important to look to those communities that have that success and understand how they implement science. So I'll pivot and turn it back to you, Robbie.
Those are some great points. Definitely time is the enemy in those cases. But I do like how you said, again, celebrating and acknowledging the successes, because we can't be so focused on what the problems are, trying to fix the problems, but focusing on the good outcomes will definitely inspire a whole generation of new resuscitationists to lead the charge. And maybe that leads into Jim, if you could talk a little bit about we have these various stakeholders, and they're all in their separate different groups responding to one of these emergencies. And Dave has said it's a cardiac arrest can be a rudderless ship. And what do we, who really is going to own being the change in sudden cardiac arrest survival?
Yeah, I mean, it's very, very challenging. I mean, I think the mantra that Dave ended with, that it takes a system to save a victim, is super relevant here. I mean, you're not going to be successful in improving cardiac arrest survival until you have all those stakeholders engaged. And you mentioned silos, and I feel like that's what I'm constantly trying to break down in our community all the time. We can train EMS providers in high performance CPR, but if the other links to the chain of survival aren't strong, I mean, I think our outcomes are going to remain bleak. I mean, we'll have wins, which is great, but over time, you're going to have trouble really consistently improving your outcomes. And we know that EMS treatment is really going to be irrelevant if we don't have other systems in place, such as bystander recognition, bystander telecommunicator CPR, AED access, rapid dispatch protocols. If none of that is there, we're just not going to be successful. I think the stakeholders are very varied. I mean, we often talk about your local hospital, medical direction, dispatch center, political advocacy groups. I think politicians are really important, but there are lots of other people who are going to need to kind of own this together. And we are all in this together. One person can't own it. That being said, I really believe that EMS has to be one of the leaders for this mission. They're just out there. They're on the front lines. But I find what's, the greatest challenges for me is really, how do you motivate those EMS stakeholders to really take ownership of their system? I'm a rural EMS medical director, and I often find myself constantly advocating for change and trying to get EMS providers engaged in this and leadership engaged. And I haven't always been successful, although I've probably been more successful than I think. We often, I think, remember our failures more than our successes. But what's interesting is, in a rural system, I've personally found in our system that I've had more success sometimes with the smaller departments more than the career departments, these sort of small volunteer departments. I've had some of them just take the ball and run with it. They own their communities. They have aggressive police AED programs. They're constantly working with their towns to launch AEDs and train bystanders and just have regular sudden cardiac arrest awareness. And one of the things that's killed this a little bit is COVID. The big bad COVID came around, and I feel like it's grounded things to a halt on a local level here. It's really hard to engage the community and hands-on. There are other ways to do it, but I believe it's probably going to take a couple of years to sort of catch back up, even when COVID is gone, to where we were. Culture, one of those things that's really hard to change, especially sometimes in the fire service. We often think of this as top down, but bottom up is also a possibility. And I have a lot of motivated frontline EMS providers, career professionals that really have changed the culture of their agencies over time and kind of got their leadership sort of engaged in improvements. And I think that's a win. It doesn't have to be top down all the time. Bottom up does work. For myself and a lot of us, I think we wish for those big improvements, right? I'm impatient. I want to improve things overnight. I think that's just not reality. I think you have to chip away at these things slowly over time and take those baby steps. And it could be a several-year process to get there, but you'll see those improvements if you just keep at it, keep chipping away, and be the crazy person who's always knocking on the doors and trying to motivate people. And whether it's top down or bottom up, I think EMS is really in the perfect position to really lead this initiative. They have to be leaders in this. I find it hard to be successful if they're not. EMS providers are visible in the community. They have the ability to engage stakeholders, both train and educate them about sudden cardiac arrest. And they're really in the perfect position to motivate other stakeholders as well and break down those silos. If they're, moving forward and they're interested in this, they can break down the silos, I think, pretty well. And really, you kind of need them to steer that ship to improve those survival rates.
Yeah, Jim well said. I think of the phrase, culture eats strategy for breakfast. We could have the best strategies in the world, and if we don't have the culture that's designed to really, bring people together towards that common goal, that common vision. I was inspired, over 10 years ago when we had some of our big changes in a system of sudden cardiac arrest survival, and I remember, 3 cases of people under the age of 50 that, had children, had young children, and they walked out of the hospital alive because bystanders were there to do amazing CPR. Our EMS systems may not be designed to get paramedics there within just enough time. And fortunately, in most of those cases, we were 3 to 4 minutes away, but still had excellent bystander CPR. And to go teach in front of the public, to go teach in front of students and introduce them as This is Michelle Haller. This is Kelly Krupe. They died in October of that year, and now they're here to talk a little bit about what you can do to help save more lives. And I think at the outset of this, it was said, it's not just the random person on the street. It's 75 to 80% of the time, it's a loved one, it's a family member, it's a friend that you're going to be around. So educating the bystanders on this with some of these more inspiring stories. I mean, the fact that their little kids didn't have to go to their mom's funeral, that they got to celebrate Christmas together that year, and to see every year getting those pictures of them, living life to the fullest, climbing the Continental Divide or going on vacations with their family is truly inspiring. And I think it creates more momentum in a system. So often we say that our systems are perfectly designed for the outcome that we're getting. So when we talk about organizational change, it's how can we change the structures and implement new structures that create new results. So maybe we can, Anne, you could chime in a little bit about the Institute of Medicine strategies to improve cardiac arrest survival, the blueprint for survival outcomes, and some of the resources that people can access to, again, design new structures to support new results.
Yeah, absolutely. Happy to talk a little bit about that. I think, just foundationally, you cannot improve that which you do not measure. So even if you start with 30 variables from each cardiac arrest, even if you start with a handful of cases, a subset of cases, just those in VF or just the ones from last month, the most important takeaway from anything I would have to say in this session is measure and improve. Start measuring your system today. Contact me if you need information on how to start measuring. And so to that, I think that there's a few resources that we should draw people's attention to. One is the Institute of Medicine publication from 2015. It's called The Cardiac Arrest Survival, A Time to Act. That report describes the public health impact and scope of the problem of cardiac arrest in the United States. And it gives specific recommendations to improve cardiac arrest survival, especially in the areas of, as I said, data collection, but also education and engagement of the public. It really emphasizes the need to centralize collection and distribution of data. So, we have CARES in the United States, but many countries around the world, PAROS in Asia, Eureka in Europe, are hard at work collecting cardiac arrest data. So that you collect the data, then you monitor it to make improvements, and that through that foundational work, we can start to break down silos, learn about our systems, and work across the continuum of the chain of survival. So they talk specifically about programs like, community tri-standard CPR. I like that, David. They talk about rapid dispatch in comm centers, telephone CPR, telecommunicator CPR, and high quality or high performance CPR. So that's definitely one for folks to check out. And then, I think that one of our faculty members document the 10 steps to improve cardiac arrest survival, written by Dr. Mickey Eisenberg, which you can find on the Resuscitation Academy website. Details 10 programs like the ones we've been discussing that give practical background and science, and then suggestions of where to start on those programs that I think is very digestible and a great place for folks to start. We also have the cardiac arrest system assessment on the Resuscitation Academy website, and I encourage folks to check that out. So it's just about 30 questions. It covers the domains of data collection, rapid dispatch, telephone CPR, high performance CPR, and early CPR and AED intervention. It's super easy to step through, and I think any one individual can step through it. An EMS medical director, an EMS provider, anybody can take it. But the real power comes when groups of those leaders from across the agency sit down and take it together. So to Jim's point about breaking down the silos, this activity, I'd imagine, so say you have an EMS chief, you have a comm center administrator, you have someone from your training, from EMS training or the comm center training, and you sit down and you take this together, and it is amazing what we see. It's truly amazing, because you can see the silos starting to break down almost right off the bat, where folks, say, oh yeah, we collect information on our telephone CPR rates. And then someone else in the room will say, oh no, we had to stop doing that, because remember, the person that was assigned to do it is now, out on leave. So we haven't done that in 3 months. What? And so we need to start doing that again. We all agree. So conversations like that are just wonderful to behold. But anyway, so the Resuscitation Academy has plenty of resources, toolkits for folks to check out that range from TCPR, HPCPR, community bystander programs, and they're all on our website, resuscitationacademy.org. Then the Citizen CPR HeartSafe community really takes the breadth of the RA teachings and creates actionable items that can be measured against criteria to get a HeartSafe community designation. And David can jump back in here, because this is really a program that's very close to his heart, pun intended. But they have over 600 communities from across the U.S. who have been working diligently to build coalitions of resuscitation leadership, and then take steps that are measurable and can be accounted for, that really prove that they're doing the work, and that the proof is in their pudding.
Lots of good puns in this in this recording for sure. David, can you give folks a brief introduction to HeartSafe communities? It's something I've been a fan of for years when I think we first met, and the concept of.
Yeah, absolutely. I'm just always learning, and I've got some of my favorite people I'm learning from with us tonight. And I'm thinking, time is the enemy. Apathy and status quo are the enemy. Art and implementation. Robbie, I love the success leaves clues. That was absolutely priceless. And, your comments about the self-assessment and inventory process, what's discovered as kind of intended consequences as part of that process is fascinating. And then, using the Institute of Medicine's, publication and report is a blueprint for improving survival nationally and locally. Again, we come back to all things are local, right? There are local situations that demand local solutions. And as you all know, my youngest son is enrolled at the Air Force Academy in Colorado Springs, and I had the opportunity a few weeks ago to drive from New England to Colorado. And I was reminded of the incredible diversity in our great nation, and how different communities are, when contrasted against one another. And Robbie, I recall, coming back fresh from Seattle. I mean, I had that Seattle strut, coming back, and I did a talk like way up in upstate New York, your home state, up near the lakes. And, I talked about citizen CPR and all of the teachings from Seattle. And, I was reminded at that conference during a break, people were like, "Hey, Dave, that was great. Cows outnumber people like 30-1 here." And I was like, hoof CPR, so, the HeartSafe program, and I take very little credit for this thing. I'm just kind of the caretaker for this fabulous landscaped garden that a whole bunch of people kind of designed and put together a long time ago. I was just left with the watering hose and a rake. But what the Heart Safe program does is it takes all of these teachings, right? Because like where we've learned, I mean, we know so much, right? And I remember sitting in academic conferences. I worked in Boston for decades, and I'd be there at Harvard or some other well-established institution. I'd listen to this academic presentation on resuscitation. I'd be like, well, if we know so much, how come we're not better at this, right? And so I was reminded of this whole challenge in implementation. And, I would have never thought, over 20 years ago, that incentivizing a community with a traffic grade road sign was going to be the impetus for action. I mean, I would have found it laughable. And actually I did. I mean, we went through with it, but lo and behold, this traffic grade road sign became the sign envy, if I may. And so elected officials want to, stay elected. And so they saw it as, oh, geez, this is something we should do. Particularly when people would see the signs and go, hey, I don't really know what those signs are, but I'd really like to have one in my community, right? So HeartSafe provides, a more workable blueprint. So I look at the IOM recommendations as being very broadly produced, right, and presented. And so the HeartSafe concept, while it isn't like really finitely boxed, it provides a little bit more of a recipe, bearing in mind that there is no secret sauce, as has already been discussed. There are no magic bullets, but it provides for a recipe so that you add the right ingredients and the right amounts at the right time and bake it at a certain temperature in order to get this cake to rise, right? And it affords local operatives to work through the process on their own. And it is an iterative process, and it takes a long time, and it isn't easy. But, it's among those things that are out there that provides a pathway, or at least a compass, for getting to your end objective, which is, our relatives, right? I mean, this is serious. It's fascinating to me. I've done presentations for large groups of regular citizens, and I look at the slide and I go, oh God, I've got an outdated cardiac arrest statistic up there. The curse of knowledge, right? And I realized one day that they didn't really care. They didn't really care if it was 450,000 or 350,000 or 256. The magic number for them was one family member, one close friend. And, I know we've got a lot of shared friends. I've lost 3 contemporaries to sudden cardiac arrest in the last 12 months. So, this is very serious stuff. We look at what we've learned from all that we've done in the past. And, COVID has to float to the top here, right? And if we look at the response at a national, regional, state, and local level, the response to COVID, I'd like to see that we've learned some lessons and that we ultimately win the war against COVID, right? But that we take what we've learned from COVID and we apply it to this other significant public health issue, and really work on improving survival. Because I truly believe for a large number of victims, this is no different than an acute allergic reaction, right? Very time sensitive, got to do a couple of things and got to do them real well. And, I'm also hearing what Tom said about, you can't fix dead, right? But we can fix STEMI, we can fix stroke, we can fix those things, but we absolutely have to have those seconds, those first few seconds, minutes matter, seconds count, mission critical, and we have to have a broad-based community approach to that. HeartSafe provides an option and pathway and guidance for that.
For more information too, we're going to create at our virtual exhibitor hall a space where we're going to outline a lot of these resources, HeartSafe Community, the ebooks produced by the Resuscitation Academy, including the blueprint and the 2015 sudden cardiac arrest survival, a time to act study. How about some final thoughts here? I mean, again, thank you all for being here, for again, your schedules aligning to have this conversation, and hopefully we can, give leaders just another tool for their leadership toolbox in order to, be the change they want to see in their communities, and just be inspired by all of you and your life's work. And again, it's an honor to be on a call with everybody, some of my heroes in resuscitation. So any just final thoughts or about this topic that or advice you have for leaders?
Don't give up. Yeah. I mean, I find that resuscitation, if done well, is infectious. If you start getting people really motivated to change the system, they'll keep on doing it. They'll be excited about it, and that just spreads. So just don't give up.
That's great.
Yeah, I would agree with Jim. I think persistence is an important attribute when it comes to resuscitation, as David said. You've got to be patient. You got to be determined. You got to keep your eye on the ball. Remember, this is a life and death activity. You're saving somebody's life. I mean, that's immense. You're not making someone's knee feel better. You're not, I mean, you are literally, it's a black and white activity here. And to save someone's life is an immense accomplishment. And so I think stay persistent, keep your eye on the ball. It's so easy, especially in EMS, to get distracted by the next thing. And people think you're boring when all you want to do is really take care of those most critical patients. But hang in there. Don't forget what really makes a difference. I think that's super important, when it comes to making a positive difference in your community.
That's great. Persistence and patience.
Yeah, and the other thing I would say is what Jim said. This can be a rallying cry for many groups, right? So resuscitation can involve the community and can be a cause, right? And your politicians can dig in, your fire departments, your community advocates. It really can be a collective, the schools. And so I think it can be a community activity that you can highlight. We need reasons to come together for positive. And this is a good one, I think.
I love that comment too. Make it a community cause. I was fortunate to be an advocate with the American Heart Association's advocacy arm around the CPR in Schools initiative that, while it didn't happen as quickly as anybody wanted it to happen, and it took us almost 5 or 6 two-year legislative sessions in New York, we finally were able to pass that in 2015 so that, 146,000 high schoolers graduate every year knowing how to save a loved one's life. I mean, that's and making it that community cause and something you would think is a no-brainer, something that could cost no money. It just took patience and persistence of all the parents who lost kids, the survivors that wanted change to happen, the pre-hospital providers that knew the secret ingredient to survival was bystander CPR. So patience, persistence, and making it a community cause for sure. How about Ann? Any final thoughts for this panel?
Just the one I've already said now. This will be the 3rd time. Just measure and improve.
Yeah.
If it's worth your effort, if anything is worth your effort, then it's worth it to measure it and improve it. And if anybody is stuck, and Robbie, I know you've got thousands of people who attend this conference, but I'm going to say it anyway. If anyone's stuck or anyone needs help, call me, email me. You can find us through our website, and Resuscitation Academy is here to help wherever you are. Even if you're just starting, or you're a super high flyer and you think you've got it figured out, but you just want more ideas, please reach out.
That's great. That's so generous. And can you give a brief, just a little bit of insight on Resuscitation Academy? Because there are global alliances as well, because this is a global community. Last year we had providers from 28 different countries attend.
Yes, absolutely. Right. So, well, the Resuscitation Academy started in 2008, and really kind of grew as this educational program that I was speaking of. It just caught people's attention from around the world. And in 2015, a group of us gathered from Asia and Europe, Australia, New Zealand, and the United States, Canada, and decided that we all should be working on the same things together. So these are like-minded folks. They're all fans of the Resuscitation Academy, working to implement the 10 steps to improve survival in their own regions. So the Global Resuscitation Alliance, .org, is kind of our sister organization. And so no matter where you are on the planet, I bet that we've got people we can connect you with who are interested in helping to save lives.
Wow, that's amazing. Thank you.
Yeah, it's very cool.
And David, maybe you could also share in your final words information on the Cardiac Arrest Survival Summit, where I was surprised myself. I didn't know that this conference existed, where people come together to really talk about the science and talk about the strategies.
Yeah, Robbie. So be careful what you wish for, right? Because once you go to the summit, it's Kool-Aid, just like, the Resuscitation Academy. So very quickly, I just got to say thank you again. Yeah. Ann, Jim, and Tom are like among my most favorite people that I learned from. And kind of my parting message, and we'll talk about the summit on the way out the door, is, it's on my shirt from Heart Safe Richland that I wore for a reason tonight. And it actually comes from a good friend of mine who's a law enforcement officer who's a significant advocate. And that's don't wait for the help. Be the help. And I think this message resonates regardless of who you are in the spectrum of, all things resuscitation related. So don't wait, be the help. EMS doesn't need to own this, altogether, because that can be overwhelming. And in fact, I recommend against that, but be the rudder of the ship, right? Guide it through the treacherous waters, guide it through the calm, peaceful waters, right? And then, there are ways to sharpen your saw, improve your craft, improve your knowledge of science, and more importantly, how to translate that artistically into, implementation. And some of the best ways to do that are through the Resuscitation Academy, and also through, there's an incredible amount of collaboration going on, which is absolutely perfect, needed, and otherwise fabulous, right? So there's a lot of collaboration going on between different organizations, and it's about time. So come to the summit in San Diego this December. The weather's going to be great. We're hopeful that it will be a in-person conference. I pray to the gods of COVID or whoever it may be that, that's possible. But within all the fabulous content there, my good friend Josh Smith from Richland, Washington, is going to be piloting a new concept, which is a community resuscitation officer program, which will provide individuals with a whole host of kind of unique skills. A lot of them like the ones that you've been working on, Robbie, kind of the atypical things that you need to be good at in order to succeed in this mission. And then lastly, I just say thank you so much to you, Robbie, you, Ann, you, Jim, Tom, and all of the people in your audience who work every day to ease pain and suffering, make the quality of life better, extend life. You're all fabulous, and I'm very grateful for all that you do.
David, thank you for those comments, for your unwavering passion for this topic. It has inspired me over the years, and thank you everyone on this panel. For more information, again, head over to our virtual exhibitor hall, and we're going to feature all these resources from both Resuscitation Academy, Citizen CPR Foundation, for more information. Everyone, thanks again for your time.